This is specifically, we are looking at patients that were enrolled into clinical trial C-08, which was a clinical trial that demonstrated that actually bevacizumab did not give benefit when added to FOLFOX for stage 2 and 3 colon cancer patients. However, bevacizumab is beneficial to metastatic patients. So I'm giving a little bit of background here. And we had hypothesized, we had seen in an unplanned analysis that there was a benefit in a subset of patients in C-08, and specifically this was a deficient mismatch repair group. And this deficient mismatch repair group has more of a tumor infiltration, of immune infiltration into its tumors. And we speculated some years ago that it was this immune response that was responsible to the benefit of Bev. And specifically, VEGF is the target of Bev, and VEGF has immunosuppressive effects. And we wanted to know whether it was perhaps this the differential immune response in the deficient group that was responsible for that Bev benefit. So we set out to characterize the immune response with markers specifically for T cells. There are 4 markers for T cells and 6 markers for immune checkpoint proteins. And these immune checkpoint proteins are important, obviously, because there are drugs that are targeted to them. We use multiplex immunofluorescence. So this was a technology that allowed us to look at as many as 7 different markers within a single tissue section. So you're able to digitally quantitate these cells, each of these cells, and their distances with respect to each other. So we were interested, obviously, in making those associations between the quantitated cells and the response either to bevacizumab or to their prognosis. So the overarching results were that there were, we set out, one, this was a pre-approved NCTN CCSC approved protocol. And there, the primary objective initially was just to look at CD8 cells and see their prognostic or predictive effect. And what we found is, yes, indeed, in CD8 cells, they are prognostic. Patients with tumors with more CD8 cells do better. But the predictive bit, which is really the important part, there was no association with Bev benefit. However, in the total cohort of patients, but importantly, when we split out the patients based on proficient group, that is the group that are stable, have stable, versus the deficient mismatch repair, or DMMR group, there was really differences in how these cells were associated with prognosis and with benefit. In other words, they were conversely related. So the proficient group, and again with prognosis, most of the T cells were prognostic, and some immune checkpoint proteins, PD-L1, PD-1. However, if we looked at the deficient group, those we didn't see that prognostic effect. But then importantly, when we went to look at prediction, meaning what group of patients are receiving benefit from Bev benefit, and looked in the DMMR group, we found that most of the T cells and the immune checkpoint proteins were associated with Bev benefit. So that, however, when we looked at the proficient group, we did not see the same effect. And in fact, importantly, with specific markers, CD8, so those are cytotoxic T cells, we think those things is good, and PD-1, those markers were associated with Bev benefit in the DMMR, the deficient group, the group that we saw benefit from Bev generally. But in the proficient group, that group actually received harm. In other words, when we split out patients that were proficient and looked at their response with Bev or without Bev, the group that just got FOLFOX did better in that proficient group, as proposed, and it was exactly the opposite effect when we looked at the deficient group, which more of those CD8 cells or PD-1 cells was better for the response to Bev. The important part is this was we looked at 1,500 patients. So this is a fairly well-powered study, although, again, this is not validation. These are observational things to be studied more in the future. One of the stumbling blocks for this is bevacizumab, as I mentioned in the beginning, is not a drug for stage 2 and 3 patients. And it may be difficult to retest Bev with FOLFOX again because this has been established now. However, I think this is an important part of this observation is when we think about bevacizumab, however, is used in the metastatic setting, and there are ongoing trials in which bevacizumab is partnered with immune checkpoint proteins. So I think this potentially gives an important way to look about how to put potentially bevacizumab with immune checkpoint inhibitors. And I think also in the metastatic setting, but I think also it kind of highlights the importance of how to tackle the combination of immune checkpoint inhibitors with other therapies, because this has been a really important consideration in the clinical field. And by that, I mean that the hope is, certainly in colon cancer and across the cancers, is these immune checkpoint inhibitors have been really dramatic and give really durable responses. And in colon cancer, in this small subset of deficient mismatch repair tumors. So the hope has been, the larger group of colon cancer patients, you'd like for these immune checkpoint inhibitors to work with them. And so maybe all that needs to be done, or one thing that can be done, is we just need to boost their immune response. Maybe what we need to do, and so there are ongoing studies, use radiation, use chemotherapy, and boost the immune response so that they'll look like deficient. They'll have this proper immune response. I think what this tells us is it's more complicated than that. It isn't just an immune response, but in colon cancer, these two groups, deficient versus proficient, with the same drug, are responding very differently, despite the fact that they have similar immune responses. Like, for instance, I said that deficient has more of an immune response. That's generally true, but there's a large range, and so far in proficient. So basically what we've been able to look at an immune response or a tumor immune response that looks similar based on the cell types we've been able to look at, and yet they look very different in how they respond to Bev. And I think it's a potential eye-opener for really needing greater understanding in order to what we should really be looking at if we really want to make more durable responses with some of these drugs that look so great in our subset of patients in deficient mismatch repair. Uniqueness of this was just the multiplex immunofluorescence. There are other ways of looking at more markers, but it's relatively new that to apply this many markers in a large clinical trial. And to see this kind of dramatic difference in responses to a drug is a central part of this.